Thanks very much for having me. And so what I thought I would do is I'm just basically going to give you a description of myself and my work history, and try and share with you what I would consider my vision here at UAB. So this basically my disclosures. Now, having gone through the first 5 years of turmoil, I sort of made a decision very early in life to go to medical school. So I'd always wanted to be a doctor as young as the age of 4. And I think that decision was largely influenced by the fact that I was very sickly as a child. So I was fortunate to get into medical school. And what we have here is actually a teaching hospital at Ahmadu Bello University, Zaria, in the 70s. And you can see that we don't have any of the tall-rise buildings we have here at UAB out there. The only 2-story building we had in that medical school was actually the pathology lab. So we had the chemistry lab, and we had the histopathology lab and the hematology lab, and that was the only story building on that campus. Now, I was fortunate that after graduating from medical school, I had the opportunity to complete my residency training at Ahmadu Bello University Teaching Hospital in Zaria. I was offered a scholarship to go obtain additional clinical training by the Foreign Commonwealth Office in the United Kingdom. And while I was there, I did further training in pediatrics, and had the opportunity to do a PhD training at Imperial College. And of course, I had a very strong attraction for infectious diseases and also immunology. So my PhD thesis was trying to define the mechanisms for immune responses to encapsulated bacterial pathogens in children. So here I was in an immunology lab doing some flow cytometry and developing a new assay, functional assay, for evaluating antibody responses to streptococcus pneumoniae in children. Now, fortunately, after completing my PhD dissertation, there was an opening by the Medical Research Council in the United Kingdom to work in Africa. So I was offered a position to work with the UK Medical Research Council in the Gambia in West Africa. So the Gambia is a very small country on the coast of West Africa. Population then was actually about just over 1 million. And my task then was to work at a very remote location, trying to set up surveillance for the causes of deaths in children under the age of 5. So this is a very rural setting where all we had was a village reporter who was very elderly, but he had this big notebook where what he does is to document the number of deliveries and the number of deaths across multiple villages. So he will go around on a regular basis and gather that information, document it, and we had a number of field staff that would go out and liaise with him and extract that information on a regular basis. And that was how we were able to gather information on the number of births and the number of deaths. Now, we had a crude way of trying to ascertain the cause of death. So what we did was to administer what we call a verbal autopsy. So a verbal autopsy is a set of questionnaires that we administer to the parents of a deceased child to try and determine the possible cause of death. Now, it's very crude, but it provided fairly useful information. So we were able to ascertain that the vast majority of children were dying from malaria or acute respiratory infections. So acute lower respiratory infections, of course, without any form of etiologic ascertainment, is very crude. And the vast majority of children out there do not have access to having a chest radiograph like we have here. So all we were able to gather was the fact that They had a febrile illness that was associated with increased respiratory rate and also increased respiratory effort. So that would give us a crude diagnosis of acute lower respiratory tract infection. But without ascertaining the cause, the etiologic cause, it's going to be difficult to come up with a preventive strategy. So we did fairly extensive etiologic surveillance that gave us the data demonstrating the fact that Streptococcus pneumoniae was actually the leading cause of death. It was the leading cause of bacteremia. It was the leading cause of etiologically confirmed pneumonia in young children in the Gambia. So we got funding support from the NIH, and we evaluated a number of vaccines. So we evaluated initially a 5-valent pneumococcal conjugate vaccine. We demonstrated the immunogenicity and safety of this vaccine. And we also demonstrated the safety of utilizing the vaccine in combination with other routine antigens for preventing infections in children. Now, we then moved on to doing a number of other studies. We looked at the impact of vaccinating pregnant women to see if vaccinating pregnant women can actually confer protection to their babies for the first several months of life through the transfer of antibodies through the placenta and also secretory antibodies in breast milk. The formulation of the vaccine used in pregnant women is very different from the formulation of the vaccine that we used in infants. Now, we also did something else that evaluated the long-term potency of the vaccine. So we looked at immunologic memory of these vaccines in children. And what we did was children who had the 5-valent pneumococcal conjugate vaccine about 24 months prior, they were revaccinated with the pneumococcal polysaccharide vaccine. And we looked at the antibody responses and also nasopharyngeal colonization by Streptococcus pneumoniae. And I just want to share this briefly. So what you see on the vaccine serotypes, so we know that Streptococcus pneumoniae, we've got over 100 serotypes, and the candidates that are included in the vaccine are actually the serotypes that are known to be most prevalent in children who have invasive disease. And the data that informed the formulation of the conjugate vaccine that we're currently using was largely generated from the United States and also from Europe. But the work we did in the Gambia a few decades ago contributed data looking at the epidemiologic distribution of serotypes. And the data we generated suggested that the prevalent serotypes here in the United States, serotypes prevalent in Europe, were very different from the serotypes causing disease in children in Africa. Now, the study we did here was basically looking at colonization of the nasopharynx in children who don't have pneumonia. So in other words, healthy children. We looked at colonization in these children as a surrogate for potential cause of invasive pneumococcal disease. Now, we evaluated children in this control group who have not received any pneumococcal conjugate vaccine, and then another group that had had the Haemophilus influenza type B conjugate vaccine. And the next panel, we have those who had 2 doses of the pneumococcal conjugate vaccine. And then the last group were those who had priming with 3 doses of the pneumococcal conjugate vaccine. Now, what I want to draw your attention to here is the fact that when we looked at the distribution of the serotypes in children who had not received any pneumococcal conjugate vaccine, you can see that this is predominantly vaccine serotypes. And then if you go down the panel, we have children who had 3 doses of the pneumococcal conjugate vaccine. So there is a significant reduction in carriage of the vaccine serotypes, but we had a significant increase in carriage of the non-vaccine serotypes. Now, this was the first report demonstrating the fact that the pneumococcal conjugate vaccine will confer protection only against serotypes included in the vaccine, but has a potential for increasing the risk of disease caused by serotypes not included in the vaccine. Now, this data informed the need to expand the number of serotypes included in the pneumococcal conjugate vaccine. So like I mentioned, this original study was done using 5-valency vaccine. And between when this study was reported, we evaluated a 9-valent vaccine, which demonstrated efficacy against all-cause mortality, all-cause hospitalization. As you can see here, it had an overall efficacy of about almost 80%. Now, in between doing the initial study on the 5-valent vaccine and doing the study on the 9-valent vaccine, it became very clear to the vaccine manufacturers that we will need to significantly increase the number of serotypes in the pneumococcal conjugate vaccine. And that's what led to the development of the 13-valent conjugate vaccine, which is what we are currently utilizing here in the United States. And of course, there are in development higher valency vaccines. There is a 20-valent valency vaccine and another 24 valency vaccine that are in development. Now, I want to shift gears very quickly to trying to transpose the experience from the Gambia to Nigeria. So we basically set up a similar surveillance platform in Nigeria with funding support from the Gates Foundation about 12 years ago. Now, unfortunately, Nigeria is one of those countries where we have very high incidence of vaccine preventable infection. So this young child here has diphtheria, and this one here has tetanus. Tetanus demonstrating action of the back, so-called opistotonic position. Now, these infections are vaccine preventable. When we set up surveillance in Nigeria to try and understand the burden of invasive pneumococcal disease, of course, for us to do this, we needed to equip several labs with these automated culture incubators. We needed to provide backup power because of irregularity of power supply from the main grid. We needed to get a -80 freezer so that we can store our isolates and subject them to further characterization outside of Nigeria because of limited capacity for doing such molecular characterization. So we had to train the laboratory scientists. And the other thing we did was to ensure that we had continuous technical supervision. So when we initiated this project, I was faculty at Michigan State University, and we typically would have senior laboratory scientists travel out with me to Nigeria to provide on-site training and on-site supervision for the team out there. I also participated in routine bedside teaching and providing seminars and lectures to the resident doctors out there on site. We ensured that this supervision was continuous, but I just want to provide a summary slide of what results we generated. In contrast to what we saw in the Gambia, the leading cause of bacteremia in children in Nigeria was not Streptococcus pneumoniae. It was actually a Salmonella typhi, which hardly existed in the Gambia during the time of surveillance work out there. So this is just one of the practical illustrations that disease epidemiology is not uniform across countries in Africa. So a lot of times we get the impression that whatever goes on in one part of Africa can be extrapolated to other parts of the continent. This is a clear example where something as seemingly trivial as invasive bacterial infection do have different etiologic spectrum depending on what country you are in on the continent. There are several possible hypotheses or explanations for this, but suffice it to say that in the Gambia, Streptococcus pneumoniae was the leading cause of bacteremia. It was also the leading cause of bacteremic deaths in children under the age of 5. In Nigeria, Salmonella typhi was the leading cause of bacteremia, but is not the leading cause of bacteremic deaths. In fact, in Nigeria, the leading cause of bacteremic deaths was actually Klebsiella pneumoniae. Klebsiella pneumoniae because of its propensity for multi-drug resistance. So we're having a lot of deaths from multi-drug resistant bacterial infections in Nigeria, as opposed to the pattern described in the Gambia. Now, the data we generated from Nigeria contributed to this global map, trying to understand the spread of a unique clade of Salmonella typhi that is multi-drug resistant that originated from India and appears to have spread into Africa through East Africa, not West Africa. Now, the data we generated over time, we pulled all the isolates together, looked at the antimicrobial resistance pattern, was what we used for approaching the NIH for this data science in Africa grant. So this is ongoing work. It's a U54 NIH grant that is supporting surveillance for antimicrobial resistance in Nigeria and also in Rwanda. And we've got multiple partners working with us on this. Now, the primary goal of this program is to try and understand the distribution of gram-negative organisms that have multi-drug resistance, to try and define the molecular basis of antimicrobial resistance, and hopefully use that information to develop new diagnostics and also new antimicrobials. So this is the University of Global Health Equity in Obaro, Rwanda. We work with some of the sites in Rwanda, and this particular site, it's in a very rural part of Rwanda, but has a lot of promise for supporting global health education with particular emphasis on needs in Africa. Now, I'm going to switch gears very quickly to sickle cell disease. I'm not a hematologist. I'm an infectious disease physician, but I got involved with doing work on sickle cell disease because of the high propensity of invasive bacterial infections in children with sickle cell disease. So this is a global map of the world illustrating the burden of sickle cell disease. And as you can see, Nigeria bears the highest burden of sickle cell disease globally. So we got involved with doing work on sickle cell disease because the vast majority of children with sickle cell disease typically present very late in the course of their illness. A lot of them present with complications, and that's typically what prompts diagnostic workup. So we have a child here presenting with hyperhemolysis and jaundice, one here presenting with chronic leg ulcer and osteomyelitis, one here presenting with acute chest syndrome, which typically mimics pneumonia, but runs a very rapidly potentially fatal course. And sickle cell disease is now recognized as one of the leading causes of stroke in young children. We have the opportunity to engage with several communities trying to promote awareness and trying to promote early diagnosis. So we worked with a team of biomedical engineers at Case Western University in Ohio to develop a point-of-care diagnosis. And this is what is being illustrated here. So this point-of-care diagnosis is supposed to be a lot cheaper and a lot more sensitive and more specific than the currently available platform across multiple sites on the continent. So this prototype has now been developed and is currently deployed across multiple locations in Africa to promote point-of-care diagnosis and hopefully increase awareness. And patients who get diagnosed promptly, the idea is to get them into preventive care so that complications, if they develop at all, would come up much later in life rather than very early in the course of the first 5 years of life. So the team that we have set up in Nigeria are currently distributed across different parts of the country, and we have microbiology diagnostic labs. We have labs that are supporting training for laboratory scientists in microbiology and also in hematology. The core team that we have also supports the Federal Ministry of Health in Nigeria in training personnel across multiple university teaching hospitals and also federal medical centers. We've had the opportunity of getting the ambassador, the US ambassador to Nigeria, visit the lab that we have set up in Abuja, which, like I said, provides a hub for training personnel across several locations on the country. And I would also say that it's the same team that we have trained in Nigeria, in Abuja, that is now providing support for training personnel in Rwanda, in Sierra Leone, and also in Liberia. Now, I think the question should be asked, why the focus on Africa? So aside from the fact that I'm African, which is sort of another disclosure, a lot of us probably would not appreciate the fact that the sheer expanse of land in Africa could take the entire United States, China, Eastern Europe, India, and France, just as depicted in this map. So you can say that it's a significant part of the world in Africa. Now, aside from the expanse of the land, we know that a significant, only about 11% of the world population is Africa. Now, unfortunately, the disease burden that Africa contributes globally is more than double that. Now, if we look at the contribution from Africa into biomedical research, it's only 2%, a very, very small fraction. Now, to compound this is the fact that when we make comparison with the number of researchers per million population, here in the US, it's over 2,000, close to 2,000 in Europe, and this is what we have in Africa. So Africa contributing significantly to disease burden globally, but with very insignificant contribution in terms of the number of researchers per million population. That gap, I would say, creates an opportunity for us to ask several questions. The other reason why it's important to pay attention to what's going on in Africa is the fact that quite a number of infectious disease outbreaks that has caused a lot of global threats or post a global pandemic threat have been traced to Africa. So we've got Ebola, we've got Lassa fever, we've got Mpox and Marburg infection. All of these have their origin in Africa. And I would dare say that the Mpox pandemic that seemed to have exploded over the past couple of years seems to have quietened down now. But in 2017, there was an outbreak in Nigeria, in the southern part of Nigeria. Now, that outbreak is actually what seeded the global pandemic. But when that outbreak occurred in 2017, it did not get any global attention at all. And even within Nigeria, the outbreak simmered very quickly Now, I would say simmered very quickly because it was very quickly overtaken by a number of other outbreaks. So we had a re-emergence of polio. There was a big meningococcal meningitis outbreak in 2017. And of course, there was a big Lassa fever outbreak in 2018. But nevertheless, that same virus ended up seeding a global pandemic. So it is not often that we get to see something like this, but the classic presentation, and unfortunately, because it had a very low case fatality rate compared to several of the other outbreaks, it did not gain the kind of attention it should have received at the national level and also at the international level, because it wasn't a problem outside the confines of Nigeria. Now, another reason why attention needs to focus on Africa is the COVID pandemic. Now, the COVID pandemic, at the onset of the pandemic, there was a lot of fear that millions were going to die in Africa. But as I'm sure a lot of you are aware, the impact of COVID in Africa ended up being very, very mild compared to the experience we had here in the United States or compared to the experience in Europe. And from a biomedical perspective, one should be asking the question, what is it about the environment? What is it about the biology of the virus that spared so many lives on the continent of Africa? There are several hypotheses out there, but within the context of what we know, that poses another important research question that could inform what may happen in the future in terms of a pandemic and how we manage future pandemics. So we had, I had the opportunity of working with a consortium that was looking at the safety of the COVID vaccine across multiple countries, including several countries in Africa. And one of the major challenges we had in generating data on safety was the fact that the vaccine uptake was extremely very low across several countries on the continent of Africa. And of course, from a social perspective, the reason why it was very low was because people did not perceive COVID as a serious health threat. So as at the end of 2022, Nigeria had actually reported more deaths from cholera during the COVID pandemic than deaths reported from COVID. So clearly, there is an important point here that in spite of the fact that we had millions of doses of COVID vaccine that were donated to the continent of Africa, the uptake was very low. It was very low because people did not perceive COVID as a threat to their health system. But unfortunately, a place like Nigeria, where we had several thousands of deaths from cholera, getting intravenous fluids for managing cases of cholera with severe dehydration, getting cholera vaccine was a challenge. So again, I want to come back to address the question of how these gaps, I believe, they create opportunities for us in addressing critical issues in global health. But before I move on to that, I just want to pause and say, let's look inwards before we look outwards. And I say that because this is a table that looked at health indices across several developed and high-income countries, and looking at expenditure, comparing expenditure to yield. So we have different parameters here: quality of care, access to care, efficiency, equity, and healthy lives. Now, if you look at the last row, which documents the cost, the United States ranks highest in terms of the cost for care. But if you look at this last column, you can see that we are ranking very, very poorly in terms of outcomes, in terms of all these indices. So we are not managing our resources optimally. And we're not making comparisons here between what goes on in the United States and any country in Africa. We are making a comparison between what goes on in the United States and other high-income countries. So there are lessons for us to learn, not just from low and middle income countries, but also from other high-income countries on how we manage our resources here in the United States. Now, I would want to suggest that as an academic institution here in the United States, with all the resources that we have, there are multiple opportunities for us to engage in transcontinental clinical educational and research activities, creating networks where we can improve the quality of our education, enhance exposure to other countries, and learn from that in navigating how we manage our resources going forward for the future. So my suggestions about how we fill these gaps, there would be opportunities for creating partnerships and building trust, opportunities for providing affordable and diagnostic platforms, particularly to low and middle income countries where those resources are difficult to come by. We can find ways in which we customize affordable treatment and preventive strategies, and this cuts across the development of vaccines, for instance. So targeting vaccines against diseases that are highly prevalent in those countries, not necessarily diseases that are highly prevalent in our setting here, but diseases that are prevalent out there. And of course, the issue of stemming the tide of brain drain from low and middle income countries to high income countries. So this, I particularly wanted to share this slide because of the expertise that I know is available here at the center. So this panel here on your left is showing one of the clinics. This is actually a hospital in northern Nigeria where the daily outpatient attendance in the pediatric outpatient unit would rank somewhere between 700 and 1,000. And if any of these patients would need to be hospitalized, this is the kind of record-keeping system that they have. So trying to find ways in which we can work with the locals out there to create a solution that will help mitigate the challenges of managing this type of system will provide learning opportunities from here for us here, will provide capacity building opportunities for them out there, and could potentially be life-saving. The majority of the children out here are presenting with an acute febrile illness, and a quick determination needs to be made whether they have malaria or they have a viral infection or they have a serious bacterial infection. You don't have an affordable diagnostic platform that can address that question in a timely manner. Now, the other problem out there is the healthcare seeking behavior. So most patients, when they are ill, it's a lot easier for them to find a clinical care provider, and without any diagnostic workup, they just get empiric treatment. And most times that empiric treatment is not one that is readily available at the healthcare facility. So they end up going to a chemist to buy over the counter, whatever it is they can afford. And unfortunately, there is no way of quality assuring the product that they get over the counter. Now, because the majority of them, when they go to a healthcare facility, they end up spending several hours before they see a care provider. And they reckon that even after seeing the care provider, the drugs on prescription may not be available at the facility. The easiest option for them would just be to walk over to a chemist or go for alternative medical care from a herbal or use herbal remedy. So I want to highlight in sort of a prescriptive summary some of the potential opportunities we may have for engagement here. So a lot of the work that we have done looking at the etiology of serious bacterial infections in children, we've generated a lot of bacterial isolates that can be characterized to develop a formulary for medications for empiric treatment. What we have done can be applied to the adult population to also generate data on serious bacterial infections in the adult population. We have the opportunity to look at host immune responses to several of these pathogens and use that to develop diagnostic tools that will be more affordable and readily available. We have opportunity to also look at etiologic agents as it relates to individuals who may have hematologic or oncologic conditions, opportunity to evaluate the epidemiology of nosocomial infections across different settings, opportunities to engage with anthropologists and social scientists in helping us to understand the sociology or the socioscience behind healthcare seeking behavior across different locations in Africa. And we do also have opportunities to engage in training in data science on the continent of Africa, creating tools that can be deployed for managing health in large populations where resources are limited. Now, what I've tried to describe to you is the tip of the iceberg, but since we don't have ice in most parts of Africa, I would say this is the hippo tip. So those of you who have had the opportunity of visiting some sites in Africa, those who live in Africa, if you go to the river and you see something like this, you have an idea what lies right under the water. So again, I would just want to say that out here, we have excellent pool of experts across different fields. And we have a unique opportunity of partnering with locations in Africa. So we can have investigators from UAB collaborating with core programs in Africa, collaborating with local investigators in Africa to jointly work on NIH grants and supporting our local scientists in Africa who may also have access to specific grants that we out here may not be able to directly compete for, but working with them to ensure that they get funded will enhance our opportunities of being more competitive for NIH grants from here. And I also want to encourage opportunities for academic exchange, partnerships that would allow faculty, students from here to go spend time in Africa to learn from our colleagues out there, and also giving them opportunities to come out here so they can learn from the resources that we have here as well. And I think ultimately that would increase global visibility overall. So just some small thoughts on global health partnerships and collaboration. The way they should work, again, sharing from the experience of individuals who have worked on this extensively, is that it's expected that there should be mutual benefit. The benefits would not necessarily be identical, but it's got to be mutual. Several of the mutual benefits will result in publications, exchange of knowledge, alliances for promotion of social justice, enhanced capacity to scale up non-effective interventions. And then I know that some of the benefits may be restricted to low and middle income countries compared to benefits that would have accrued to us here in the high income settings, but the parallel benefits to both parties. And of course, we need to go into these partnerships, identifying the fact that there will be challenges because the resources available in several of these LMIC settings are very different from the resources that we have here. And trying to find a way in managing these benefits, managing the resources, managing the challenges in an equitable manner will strengthen the partnership and will provide sustainability. So in a lot of ways, it's a partnership that will be mutually beneficial and will be helping each other grow. And indeed, that's what true friendship is about. Now, the risk we face with just trying to ignore everything is that, as we have learned from the past few years, the microbe that felled one child in a distant continent yesterday can reach yours today and seed a global pandemic. So if we take that approach, we would want to provide a shield of protection for any kind of potential outbreak that is happening any part of the globe, to ensure that that local protection is actually indirectly conferring protection on ourselves. Now, this is a Swahili proverb in Africa that says, if you want to go fast, go alone. If you want to go far, go together. And I think that highlights the importance and the strength of collaborative partnership. This is the local team that I have working on the multiple projects we have in Nigeria, and also supporting work in Rwanda. And I want to thank you very much for your attention.